Welcome back to the deep dive. Today we are doing a really focused, very rigorous session. We've designed this specifically for anyone preparing for the Gujarat University MD Anesthesiology examinations. We're diving deep into supraglottic airway devices, SIADs. This is a cornerstone topic, and you just have to have absolute mastery of it for both your written papers and your Viva.
That's absolutely right. I mean, if you look at the DNB and university trends, SGADs just appear constantly. They really do bridge that gap between, basic life support and more advanced airway management.
Right.
And this isn't about just knowing the textbook definitions. It's about understanding the clinical implications behind every single design feature. So our mission today is to distill all this material into a perfectly structured, high-scoring revision blueprint.
Okay, let's do it. Let's unpack this with that rigorous exam focus in mind. I think we should start with the foundations, the stuff that gets you those easy initial marks. So defining our subject.
Right. So we start with the definition of an SGAD. The key concept, and you have to articulate this very clearly, is that these are devices inserted blindly into the pharynx.
Blindly, okay.
Yes. Their core function is to provide a patent conduit, a clear pathway for gas exchange. That means ventilation, oxygenation, and of course the delivery of anesthetic gases.
And I think the crucial distinction, and really the reason they changed the entire landscape, is that they achieve effective airway control without needing to go into the trachea. They don't require tracheal intubation.
Precisely. That is the key.
Yeah.
And if we break down the components, every SGAD is really made of two primary parts. You have the airway tube itself, which ends in that standard 15-millimeter connector we see everywhere in anesthesia. And then you have the hypopharyngeal device, or the mask. And this mask is designed to create a seal, directing airflow down towards the glottis and the lungs, while, and this is a critical variable, simultaneously occluding the esophagus. But it does that with varying degrees of effectiveness.
It's just incredible to think that in the last 40 years, the development of SGADs is, well, it's arguably one of the most important advancements in airway devices.
It really is.
They've defined this key intermediate step. It sits so firmly, so purposefully between the often unreliable face mask and the definitive but much more invasive endotracheal tube, the ETT.
And now they're the primary choice for countless diagnostic and minor surgical procedures. They're the workhorse.
But it's not just about routine cases, is it? Their real fame comes from crisis management.
That's right. And this brings us directly to their non-negotiable importance in the difficult airway algorithm, the DAA. Yeah. The laryngeal mask airway, the LMA, as the archetype, is a pivotal, mandatory component of the American Society of Anesthesiologists, the ASA's difficult airway algorithm.
And this is where that life-saving potential really comes into play. They function as a critical life-saving temporizing measure in that scenario every single anesthetist dreads.
The CICO.
The cannot intubate, cannot ventilate scenario. When everything else has failed, the LMA still has this incredibly impressive success rate. It's cited consistently between 95 and 99%.
That number alone justifies its inclusion on every difficult airway trolley in the world.
Wow.
When you answer an exam question on this, you have to articulate that rescue role eloquently. SGADs prevent hypoxic brain injury. That's the ultimate disaster. They buy the clinician critical time to call for help, time to adjust their technique, or, time to prepare for a surgical airway. They transform a crisis into a manageable sequence.
So if we look at the common exam question patterns, especially looking at DNB trends, what's the recurring focus? What do they always ask?
The recurring theme is comparison. Questions will frequently require you to tabulate the differences. That's a huge clue that you must know the specs cold.
Ah, okay.
We see direct comparison requests for the second-generation devices all the time. ProSeal LMA versus the iGel Airway, or LMA Supreme versus the classic LMA. This means rote memorization of the design, the seal pressure, and all the features is just essential for those comparison tables.
And beyond just the tables, what else do students need to master?
You need to show a systematic understanding. Master the classification, which we're getting to next. Know the specific complications, especially the ones related to cuff pressure, and be able to detail the specific role in the ASA-DAA. That includes knowing things like the Chandy maneuver for intubation. This kind of systematic approach is what transforms a basic answer into a high-scoring one.
Okay, that's a great frame. So given that classification is flagged as very high yield, let's structure this part very precisely. We need to understand the basis for the categories as well as the categories themselves.
Absolutely. The foundation of SGAD classification, and this is the most relevant system for both clinical prediction and for exams, is based on the device's sealing mechanisms.
Okay, the seal.
Yes. This is often attributed to Miller's classification system.
Yeah.
And understanding the seal is key because it tells you two things immediately: the maximum achievable seal pressure and, critically, the device's potential for gastric access and aspiration protection.
So it's the functional capability that drives the categories, not just the history of the device.
Exactly. So let's start with the foundational group. First generation SGADs. These are fundamentally peri-laryngeal sealers.
Peri-laryngeal.
They operate without any specialized features like directional sealing or separate esophageal sealing cuffs. They just establish a basic ring seal right around the laryngeal inlet.
So the classic LMA, the intubating LMA or LMA, and the disposable LMA unique, they all fall squarely into this category. They represent that initial design philosophy.
Correct. Now, moving on to second-generation SGADs, this is where the innovation really leaps forward. These devices are defined by incorporating critical features that are intended to enhance both performance and, crucially, safety.
Okay, what are we looking for?
We're specifically looking for two innovations: an improved higher-pressure seal and dam, the crucial inclusion of a gastric drainage channel, a GDC. This is to actively reduce the aspiration risk.
The GDC, that sounds like the conceptual line in the sand. It's trying to functionally separate the respiratory and GI tracts, which was kind of the Achilles heel of the first generation.
Absolutely. The A-list examples here are the ProSeal LMA, or PLMA, the LMA Supreme, the Cuffless eye gel, the Laryngeal 2 suction, or LTS2, and devices like the Ambu Oregon. You need to know these names, their specific features, and exactly how they stack up in a comparison table.
We should probably briefly mention the other categories in Miller's system just to show comprehensive knowledge, even if they aren't the clinical workhorses.
Yes. For a complete answer, Miller also defines 1. Cuffless anatomically pre-shaped sealers. The textbook example here is the streamlined liner of the pharynx airway, or SLIPA. And although the eye gel fits this description because it is cuffless, its clinical importance is really defined by that GDC, which usually places it in the second generation category for any practical discussion.
And the other category?
2. Cuffed pharyngeal sealers. These devices have active esophageal sealing cuffs, which means they target the esophagus much more definitively than the first two groups. Examples would be the laryngeal tube, or LT, and the esophageal tracheal combo tube, the ETC. Knowing this detailed classification, peri-laryngeal sealers, cuffless pre-shaped sealers, and cuffed pharyngeal sealers, that will earn you significant marks in a classification question.
That structure is crystal clear. Let's now jump into the detail of the original innovator, the classic LMA.
The classic LMA, the CLMA, is really where the revolution began. We have to start with Dr. Archie Brain. He developed the device back in 1982 and brought it into clinical use by 1988. It was a really simple modification of the existing Goldman dental mask, but that simple change just fundamentally shifted how we manage the airway.
So what are the key components we need to be able to describe for the exam?
You describe an elliptical silicone mask that's attached to a latex-free silicone tube. The mask has an inflatable outer rim, or cuff. The tube ends proximally in that standard 15mm connector. And crucially, on the laryngeal inlet surface, it has what are called aperture bars, sometimes called the epiglottic elevating bar.
And what do they do?
They're designed to prevent the epiglottis from folding over and obstructing the airway inlet, either during insertion or ventilation. And for the reusable CLMA, remember its lifespan, up to 40 uses, and it requires strict autoclaving and sterilization protocols.
The working principle is often overlooked because it seems so simple, but it's key to understanding its limitations.
It is. It creates a low-pressure seal around the laryngeal inlet. So when the cuff is inflated, the mask settles, with the distal tip lodging against the upper esophageal sphincter, the sides filling the piriform fossa, and the upper part sealing against the base of the tongue and the palate. This gentle positioning is what enables positive pressure ventilation, or PPV. When the cuff is inflated with the correct volume, the device should rise slightly out of the hypopharynx, and that signals proper seating.
Now, let's tabulate these crucial advantages that examiners are looking for, the reasons why we would use an LMA instead of a face mask or an ETT.
Okay, so compared to the face mask, the LMA offers significantly more secure and reliable ventilation. Clinically, it frees up the anesthetist's hands. You don't need that continuous jaw thrust.
Right.
It's also rapid and successful, even in the hands of non-experts in pre-hospital settings. Now, compared to the ETT, the benefits are really rooted in it being less invasive. So you get reduced hemodynamic and stress responses, a minimal increase in intraocular pressure, or IOP, and less reliance on heavy sedation. The pivotal point is that neuromuscular blocking drugs, or NMBDs, are not required for LMA insertion.
And that facilitates faster recovery and turnover. That's huge.
It is, but we have to address the major limiting weaknesses, the things that really spurred the next generation of devices.
Okay, the downsides.
Absolutely. The 2 points that must be stated are the low seal pressure and the lack of aspiration protection. The classic LMA typically only achieves a seal pressure of about 20 centimeter H2O.
Just 20.
Yes. So any need for higher inspiratory pressure, say due to low lung compliance or high resistance, will lead to a leak. That compromises ventilation and increases the risk of gastric insufflation. And while it's better than a face mask, it provides no definitive protection against aspiration.
And what about patient comfort?
You can't forget that. The high rate of postoperative sore throat. It's reported at a significant 17% compared to just 3% with a face mask.
So the classic LMA is really indicated primarily for general anesthesia in elective minor surgeries or as a fundamental rescue device in difficult mask ventilation.
That's its lane, exactly. We should also briefly mention the other first-gen devices just for completeness. The LMA Unique is simply the single-use, disposable sibling of the classic LMA. It's a cost-effective choice for hospitals. And then there's the flexible LMA, which is essential for specific surgical fields. Its tube is wire-reinforced, so it's kink-resistant, it's longer, and it has a smaller diameter. This allows the airway tube to be positioned away from the head and neck surgical field, though that design does make it structurally unsuitable for intubation.
Okay, here we hit the heart of the evolution. The second-generation SGADs. These are the exam favorites because they directly address those first-generation safety gaps. What is the fundamental design difference we need to focus on?
Right, we're focusing on safety and performance enhancement, and the most defining feature is the gastric drainage channel, the GDC.
The GDC?
The GDC runs parallel to the airway tube, and it serves a critical dual function. First, it allows us to pass a thin orogastric tube for gastric decompression or suctioning. Second, and this is crucial, if regurgitation occurs, the GDC channels those gastric contents away from the airway and out of the patient's mouth. This dramatically improves safety and partially isolates the respiratory and GI tracts.
That channeling function is a huge mitigating factor against that aspiration risk.
It is. And the second hallmark feature is the improved seal. These devices incorporate advanced cuff geometry or materials that are designed to withstand significantly higher peak inspiratory pressures compared to that 20 centimeter H2O limit of the classic LMA. This enhanced seal is what allows us to use them in more challenging clinical settings.
Let's detail the top 3 devices, starting with the innovator of the second generation, the ProSeal LMA.
The ProSeal is really distinguished by its design refinements. It features an additional posterior or dorsal cuff, which acts to push the mask forward against the peri-laryngeal structures, and that significantly improves the seal. It has a robust double tube arrangement, the reinforced airway tube, and the drain tube, which prevents the device from rotating once it's seated. It also incorporates a built-in bite block to protect the tube. Clinically, the ProSeal achieves a seal pressure of 30 centimeter H2O, a substantial improvement over the classic LMA.
And the insertion technique can be a little more complex, right?
Yes, it can be. Insertion can be done manually, but the specialized technique involves guiding it over a bougie that you've deliberately placed into the esophagus first. This ensures perfect alignment and proper seating in front of the laryngeal inlet, making the insertion highly reliable, even in, anatomically challenging cases.
Next, the LMA Supreme. I understand this one is pre-shaped, which gives it a bit of a structural advantage.
The Supreme is designed for single use, and it's latex-free. Its defining characteristic is that rigid, pre-shaped tube. It's designed with a very pronounced curve to naturally adopt the anatomical contour of the pharynx and hypopharynx.
So it just slides into place more easily?
In theory, yes. It features an integrated bite block and a GDC. And to prevent the epiglottis from obstructing it, its cuff has molded fins. Performance-wise, it pushes the limits even further, achieving seal pressures up to 37 centimeter H2O.
Wow.
Now, the absolute exam trap here, which you must avoid, is confusing its rigidity for intubating potential. And this is critical. Intubation is not possible with the LMA Supreme. It is purely a high-performance ventilating device.
Got it. Okay, finally, the fascinating cuffless favorite, the iGel. This seems like a completely different concept.
It is. The iGel is categorized as a cuffless, anatomically pre-shaped sealer. It's almost like a thermoplastic boot. It's made of a unique polymer that, once it's inserted, warms up to body temperature and softens in place.
Oh, that's clever.
It is. This thermomolding characteristic enhances the anatomical fit and improves patient comfort, often leading to less sore throat post-operatively compared to the cuff devices. It includes a gastric drainage port. But while it's incredibly popular and very fast to insert, its seal pressure is typically described as intermediate. It's functional, reliable, better than the classic LMA, but perhaps not reaching the maximum seals of the cuffed second-gen devices like the Supreme.
So if we synthesize all of this, what is the clear clinical advantage of the entire second-generation class over the first? This is a guaranteed comparison question.
Right. The fundamental advantage is the expanded clinical utility because of the enhanced safety. Higher seal pressures mean we can use positive pressure ventilation at increased area pressures. This expands their use into procedures like selected laparoscopic surgeries and even non-supine positions prone lateral, where seal stability is crucial.
And the GVC.
And crucially, the GDC addresses the primary safety concern, aspiration risk. This allows us to contemplate their use in patients with marginally higher risk profiles, which was just impossible with the classic LMA.
Moving from the design to the application, the insertion technique is definitely high yield for the Viva. What are the non-negotiable steps for preparation?
Preparation is everything. First, size selection. It has to be accurate. You need to know the standard size ranges size 1 for neonates up to size 6 for the largest adults, over 100 kilograms, because the chosen size determines both the seal and the final position.
Okay.
Second, meticulous lubrication is mandatory. Use a water-soluble lubricant and apply it only to the posterior surface of the mask. You don't want to block the aperture.
But I think the most critical preparation step isn't mechanical, it's physiological, right? The depth of anesthesia.
Absolutely. Insertion must occur during a period of adequate suppression of pharyngeal and laryngeal reflexes. If those reflexes are active, you risk coughing, retching, and catastrophic laryngospasm. You must emphasize that while muscle relaxants are not needed, adequate depth is. Propofol is specifically cited as a highly suitable induction agent because of its excellent properties in suppressing those laryngeal reflexes, which facilitates a smooth placement.
Okay, so once we're prepared, let's detail the steps. What's the generic SGA insertion method?
Typically, the patient is supine. You might need a slight jaw lift to ensure a clear pathway. The technique involves holding the device with your dominant hand and directing the tip against the hard palate, making sure the mask aperture is facing the patient's toes.
Okay.
You advance it into the oropharynx, often with a gentle twisting motion to get around the base of the tongue. You continue advancing until you feel a definitive resistance. This means the tip is seated against the upper esophageal sphincter.
And then, for a cuff device, the crucial next step is inflation.
Yes. You inflate the cuff with the recommended volume, but critically, you have to watch the device. It should rise slightly as it settles into the correct hypopharyngeal position. Excessive volume, however, risks increasing the cuff pressure above the therapeutic range, and that can lead to complications.
And what about that specific rotation technique for the classic LMA? Is that still widely taught?
It is taught as an alternative, mainly to prevent the tongue from folding back. In the classic LMA rotation technique, you insert the device with the curvature facing cranially, so towards the upper lip.
Upside down.
Essentially, yes. Once the tip is about halfway past the mouth, you rotate it 180 degrees and then advance it until the flange rests outside the lips. This is designed to maximize the chance of the LMA sliding smoothly down the posterior pharyngeal wall without catching the epiglottis or pushing the tongue backward.
Finally, for a safe answer, we have to confirm placement. What are the required indicators?
You need a checklist. 1. Auscultation. Check for bilateral lung sounds. 2. Chest excursion. Observe bilateral chest rise. 3. Gastric insufflation. Make sure there's no obvious air entry into the stomach. And 4. Capnography. This is the essential, non-negotiable confirmation.
Gold standard.
Absolutely. Capnography confirms the presence of end-tidal CO2, verifying that the device is correctly positioned in the airway and that effective gas exchange is happening. Our sources highlight its necessity, especially in high-stakes scenarios like CPR.
Okay, let's transition into the numbers and pressures, the physiological context that determines the safety margin. First, how do SGADs affect ventilation dynamics?
They're very versatile. They permit both spontaneous ventilation and controlled positive pressure ventilation, or PPV. A known benefit is that using an SGAD is associated with reduced gastric distension compared to what you might see with aggressive bag valve mask ventilation alone, because the SGAD provides a relatively sealed conduit.
Let's focus on the crucial numbers that examiners love. The airway seal pressure. This is the hard limit.
You must know this trio perfectly. This hierarchy directly determines the clinical utility. The classic LMA seal pressure, typically 20 centimeter H2O. That's the baseline.
20.
The ProSeal LMA seal pressure, approximately 30 centimeter H2O. A significant step up.
30?
And the LMA Supreme seal pressure, the highest, up to 37 centimeter H2O.
So if a patient needs high PEEP or high peak pressures because of, say, low pulmonary compliance and a restrictive lung disease, that 30 centimeter H2O mark acts as a definitive contraindication, right?
It acts as a relative contraindication. If your peak inspiratory pressures consistently need to exceed 30 centimeter H2O, you are at a very high risk of breaching the SGD seal.
And what happens then?
When the seal is breached, the air will find the path of least resistance. That usually means air leaking into the mouth or, worse, into the stomach. That leads to gastric insufflation and an increased aspiration risk.
And how does the second generation mitigate that specific gastric insufflation risk?
It's the GDC again. While high pressures can still breach the seal, second-generation devices significantly reduce the consequences of that insufflation. If air does enter the stomach, the GDC allows for the passive release of that trapped air. This prevents excessive gastric distension, which not only impairs diaphragmatic movement, but also dramatically increases the risk of regurgitation. This safety margin is precisely why they are superior for PPV.
And beyond just ventilation, what about the cardiovascular and neurological effects?
Right. Compared to the mechanical stimulation of direct laryngoscopy and ETT insertion, SGAD insertion causes a significantly reduced hemodynamic response. So less tachycardia, less hypertension. This reduced stress response is key in patients with compromised cardiac function. Furthermore, the less invasive nature leads to less of an increase in intraocular pressure, or IOP. This is a noted benefit, particularly for devices like the iGel and LMA Supreme, which makes them excellent choices for eye surgery, where IOP fluctuation is critical.
Right, the functional section. We know SGDs are versatile, but we need to be able to list the clinical uses with authority.
Start with the most common use, elective surgery. They are the routine choice for general anesthesia in diagnostic, superficial, or minor surgical cases, where the procedure is short and the patient has a low aspiration risk.
Okay, and moving to the high-stakes applications. Difficult airway management.
They are critical for two related conditions. First, they're indicated when we anticipate difficult mask ventilation. They secure the airway far better than a face mask. And second, they serve as the crucial rescue device in the unanticipated difficult airway or failed intubation scenario.
Let's elaborate on their role as a rescue airway in failed intubation. This is where they secure the pass mark in the Viva.
They are the mandated bridging device for effective oxygenation when tracheal intubation fails. But they don't just provide ventilation. They can actively serve as a conduit to facilitate definitive airway placement. Specifically, devices like the Intubating LMA, the ILMA, can guide an ETT or a flexible fiber optic bronchoscope into the trachea, transforming a failed intubation attempt into a successful one through a specialized technique.
And we can't forget the out-of-hospital setting where simplicity is absolutely king.
Pre-hospital and emergency settings are a massive area of utility. During CPR, SGADs provide rapid, reliable airway security. Because they require minimal training for successful insertion, clinical or even non-clinical staff can secure the airway quickly, allowing for continuous chest compressions with minimal interruption.
Finally, what about the specialized uses that the improved safety of the second generation allows for?
Right. Thanks to their improved seal in the GDC, we've successfully migrated SGAD usage into areas that were previously restricted to the ETT. This includes select laparoscopic surgeries, like a lap cholecystectomy in non-obese patients, where they can manage the increased intra-abdominal pressure without massive gastric distension. Their stability also makes them suitable for non-supine positions, like lateral or prone. We even see reported use of the LMA Supreme in specific low-risk obstetric cases, such as C-sections for fasted, non-obese patients, balancing rapid airway control with reduced invasiveness.
Every powerful tool has its limits. We have to detail the absolute and relative contraindications to show that clinical judgment.
The primary limitation, the one that overrides almost everything else, is the risk of aspiration. SGADs, even the best second-generation ones, do not provide the definitive aspiration protection of a cuffed ETT.
So who is high risk?
They are contraindicated in patients with a documented full stomach, severe reflux disease, morbid obesity, or a known large hiatus hernia. These are high-risk scenarios where a definitive tracheal seal is mandatory. No exceptions.
Are there anatomical constraints that would prevent us from even getting the device in?
Yes. SGAD insertion relies on the pharyngeal space. So patients with reduced mouth opening, like trismus, a fixed cervical spine, a very large tongue, or greatly enlarged tonsils. It might be difficult or even impossible to insert an SGAD. A large posterior larynx can also block that smooth advancement.
And what if the problem isn't above the cords but below them?
That's a crucial differentiator. SGADs are completely ineffective if the upper airway obstruction is located below the level of the vocal cords. If you have a tracheal mass or significant subglottic stenosis, the SGAD will just seal the larynx, but it won't bypass the obstruction. You're then looking at a surgical airway or rigid bronchoscopy.
And finally, we revisit the operational constraints, things like surgical positioning and duration.
They're ill-advised in procedures where the airway is shared. Some ENT surgeries, for example, because the displacement risk is just too high. They're also generally not recommended for prolonged surgery where long-term, precise ventilation control is paramount.
Except for the flexible LMA.
The flexible LMA is the exception for head and neck surgeries, as it can be routed away from the operating field. But remember that 30-centimeter H2O sealing, if the surgical requirements push ventilation pressures consistently beyond that, the SGAD has to be swapped for an ETT.
Okay, let's discuss the inevitable adverse events. We need to know the most common complications and, more importantly, how to prevent them.
The most common complication, and one you must cite accurately, is post-operative sore throat. It affects a considerable 17% of LMA users. That's a stark contrast to the 3% you see with a face mask.
And the primary cause of this is the cuff pressure, correct?
Precisely. Excessive cuff pressure exerts force on the surrounding pharyngeal and laryngeal mucosa. This leads to mucosal trauma, edema, and subsequent pain. This leads directly to the exam-critical preventive measure: the absolute necessity of maintaining cuff pressure within the recommended therapeutic range of 40 to 60 centimeters 2O.
How do you do that?
Ideally by using manometry, rather than just relying on the subjective feel of the pilot balloon. This practice drastically reduces adverse events.
And sustained high pressure can lead to something more serious, like nerve injury.
Correct. We occasionally see oropharyngeal morbidity, including nerve palsies, associated with high or prolonged cuff pressures. This just reinforces the principle. You must measure and maintain pressure vigilantly throughout the case.
And despite the GDC, aspiration still remains a risk.
It does. While the risk is low, cited around 0.012% with the LMA, it is never zero. Examiners want to hear that second-generation devices are designed to mitigate this risk, but that their presence does not negate the need for rigorous aspiration prophylaxis and careful patient selection.
What about simple mechanical failure or just improper insertion?
Malposition is common. It can happen if the patient is too light, if the size selection is wrong, or if the anatomy is difficult. Large tongue, posterior larynx. Malposition usually manifests as a partial airway obstruction, characterized by leaking air, reduced tidal volumes, and potentially a delayed capnography waveform.
And the fix.
Management is immediate correction, adjustment, or removal and reinsertion, possibly with a different size or even a different device.
Are there any specific, less common complications we should be ready to talk about?
Yes. Laryngospasm can be triggered by inadequate anesthesia, depth, or irritation of the laryngeal structures by the device itself. Uvular trauma has been reported, usually associated with a forceful insertion. And lastly, certain SGADs with large proximal cuffs, like the laryngeal tube series, have been linked to tongue engorgement.
Wow, what causes that?
It results from obstructed venous outflow due to pressure on the lingual veins. This is a severe, though rare, complication that requires careful monitoring, especially during prolonged use.
This section defines the SGAD's relevance in critical care. It's the highest stakes clinical topic. Where exactly does the SGAD sit in the difficult airway sequence?
Right. When you're faced with an unanticipated difficult airway, the sequence is very clear. If mask ventilation fails and tracheal intubation fails, you enter the CICO sequence: cannot intubate, cannot oxygenate. The SGAD is the mandated, crucial step for rescue oxygenation.
Before a surgical airway.
It is utilized prior to resorting to an invasive surgical airway, like a cricothyrotomy. Its ability to provide that 95–99% success rate in this desperate moment makes it absolutely invaluable. It is the bridge that keeps a patient alive and prevents hypoxic brain injury.
So it's the mandatory pause before picking up the scalpel. But certain SGADs don't just ventilate, they can actually help you intubate.
That is their role as a conduit for intubation. While you can pass a small ETT through some SGADs, the device specifically engineered for this is the intubating LMA, or ILMA, also known as the LMA Fastrach. Its design, the rigid construction, the handle, the specific dimensions, allows for a very high success rate of blind tracheal intubation, cited between about 89% and 100%. This is the device you turn to when you need the definitive airway but cannot achieve it conventionally.
And this leads directly to the maneuver examiners love to ask about in the Viva, the Chandy maneuver. What are the mechanics of that?
The Chandy maneuver is a very precise two-step process used with the LMA, and it relies on that rigid handle. Step 1 is the ventilation check. The clinician slightly rotates the LMA, using the handle to find the position of optimal ventilation. You confirm this with bilateral lung sounds and capnography. Step 2 is intubation facilitation. Just before advancing the special LMA Fastrach ETT, the FEC-ET, the handle is used to gently lift the LMA forwards by a few millimeters, without tilting the distal end.
Why is that slight forward lift so critical for a successful intubation?
That lift achieves two things simultaneously. First, it helps to perfectly align the axis of the ETT with the tracheal axis. Second, the internal epiglottic elevating bar lifts the epiglottis, ensuring that the ETT passes into the trachea rather than slipping down into the esophagus. If you tilt the device, you might lose the seal. The key is that straight, small lift that optimally positions the tracheal inlet relative to the ETT tip.
Now we structure the high-yield comparison tables for the exam. Let's start with the evolution. First generation versus second generation SGADs.
This needs to be presented very clearly in the written exam, so let's just run through it. First feature, gastric drainage channel.
For first gen, that's absent.
Absent. For second gen, it's present. That's the major safety feature.
Okay. Seal pressure limit.
Low for first gen, typically 20 centimeter H2O. For second gen, it's high 30 to 37 centimeter H2O.
Aspiration protection?
For first gen, inferior. It's only slightly better than a mask. For second gen, superior because of the GDC.
And as an intubation conduit.
For first gen, you'd need adjuncts or the specialized LMA. For second gen, you have to remember that the Supreme cannot be used, but something like a ProSeal or Oregon can be used to guide tubes.
The implication being that the second generation significantly expanded the indications, moving SGADs from just a rescue device to a genuine elective alternative in certain low-risk groups.
Exactly. Now, the essential comparison for understanding clinical limitations, SGADs versus endotracheal intubation. The ETT. This distinction demonstrates your grasp of definitive airway control.
The seal is the primary difference in both function and safety.
Correct. The ETT provides a tracheal seal. It's definitive, and it offers maximal aspiration protection. SGDs, on the other hand, provide a periglottic seal, which is non-definitive. It relies on pressure and anatomy.
And airway pressures.
For ETT, it allows for the high pressures required for very low compliance lungs. SGAD are capped, ideally under 30 centimeter H2O.
What about the pharmacology requirements?
SGADs require only adequate sedation, like propofol, to suppress the reflexes. No NMBDs needed, so you get rapid recovery. An ETT typically requires full muscle relaxation for safe insertion and intubating conditions, which extends recovery time.
And the trade-off is trauma?
SGAD insertion is minimal trauma, reduced hemodynamic response, and a lower IOP rise. An ETT carries the inherent risk of dental or laryngeal trauma, vocal cord injury, and a much greater overall hemodynamic stress response due to the required laryngoscopy.
For the VIVA, what's the crucial final exam-oriented comparison point, the summary statement?
You should never equivocate on safety. You must conclude that in scenarios involving high aspiration risk, so morbid obesity, an emergency, a full stomach, the ETT remains the definitive gold standard. However, you then demonstrate your nuanced knowledge by stating that second-generation SGADs are now considered adequate and safe alternatives in selected non-high-risk cases because of their improved seals and the critical inclusion of the GDC. The choice is always a risk-benefit assessment.
Let's switch modes entirely and anticipate the questions coming from the senior faculty across the table, the key facts that just have to roll off the tongue instantly.
Okay, here are the frequently asked VIVA questions that are aimed at rapid conceptual recall. First, define CICO and where exactly does the SGAD fit?
And the answer?
It is the mandatory rescue oxygenation step between failed intubation and ventilation and invasive surgical access like a cricothyrotomy.
Next, what is the Chandy maneuver and why is it performed?
It's the two-step process used with the LMA. Gentle handle rotation for optimal ventilation, followed by a slight forward lift without tilting to align the ETT axis and lift the epiglottis bar.
What are the specific seal pressures of the LMA Classic and the ProSeal?
20 and 30 centimeter H2O, respectively. You have to be precise with those numbers.
What is the biggest limitation of SGADs?
The lack of absolute aspiration protection, that definitive seal provided by a cuffed ETT.
And finally, what is the therapeutic range for LMA cuff pressure?
40 to 60 centimeter H2O.
Now, let's highlight the traps that are designed to catch candidates out. Avoiding these shows true clinical maturity.
The first trap focuses on the prerequisites for insertion. The trap is assuming that SGAD insertion requires no specific depth of anesthesia. The safe answer is that you must stress that insertion requires adequate suppression of laryngeal and pharyngeal reflexes. While this often mandates agents like propofol, it's essential to clarify that muscle relaxants are not required, distinguishing it from ETT placement.
The second major trap differentiates the roles of the second-gen devices.
This is a classic differential question aimed at device selection. The trap is assuming the LMA Supreme can be used for intubation because of its rigid structure and high performance. The safe answer is to clearly state that intubation is not possible with the LMA Supreme. It is solely a ventilating device, while the intubating LMA, the Fastrach, remains the dedicated conduit.
And the final safety-related trap we keep coming back to.
Trap, ignoring the need for cuff pressure monitoring. The safe answer is that you must highlight the importance of using manometry to prevent pressure-related complications, like sore throat and nerve injury, and you cite the therapeutic range of 40-60 cm H2O. This demonstrates that you prioritize patient safety beyond just a successful insertion.
For the long-written answers, diagrams aren't really optional. They maximize your marks. What should a candidate prioritize drawing to illustrate the key differences?
Your diagram should illustrate the evolution from simple to complex, and you have to focus on the differentiating features, especially the GDC.
So start simple with the classic LMA.
Right. Draw the basic. The smooth elliptical mask, the single airway tube, the 15mm connector, and those internal aperture bars. Label them all clearly.
And for the ProSeal LMA, the drawing must immediately showcase its dual functionality.
You need to clearly show the double tube arrangement, the reinforced airway tube, and the drain tube running parallel. And crucially, you have to illustrate the additional dorsal cuff, that posterior cuff that enhances the seal. And then trace the path of the gastric drainage channel right down to its opening near the esophageal sphincter.
And for the iGel, emphasizing its unique material and cuffless nature.
The iGel diagram has to show that unique, anatomically pre-shaped boot shape. You have to emphasize its cuffless nature, made of that thermoplastic material, and clearly show the separate gastric drainage port and the integrated bite block.
What are the specific labeling points that are going to earn marks?
On every diagram, label the 15mm connector. For the second-gen devices, always label the gastric drainage channel or port and the integrated bite block. And on the ILMA or Fastrach, you have to highlight the rigid handle and the specialized epiglottic elevating bar inside the mask. Examiners look for these technical features.
Finally, we've covered a lot of ground. How does a candidate synthesize all of this into a structured, high-scoring, 20-mark answer?
Structure is everything under exam pressure. You should use the 14 headings we've discussed in this deep dive as your mandatory framework. Start with definitions and classification, get the high-yield facts down first. Then you proceed systematically. Cover the detailed design features, compare the generations, detail the insertion steps, list the clinical applications, indications, and contraindications, cover the inevitable complications, especially sore throat and cuff pressure, and then conclude with the device's crucial role in the DAA and CICO algorithms. This systematic approach guarantees coverage and maximum marks.
That structure is perfect for the exam. Now, for the rapid-fire recap, the 10 to 12 definitive take-home points that have to be memorized before walking into the exam hall.
Okay, commit these to memory. 1. SGADs are the non-invasive airway workhorses, invented by Dr. Archie Brain, bridging the mask and the ETT.
2.
Classification is based on the sealing mechanism. No first gen like the CLMA and second gen like the ProSeal, iGel, and Supreme.
3.
The classic LMA is limited by a 20 cm H2O seal pressure and lacks aspiration protection features.
4.
Second-generation devices achieve high seal pressures. ProSeal 30 cm H2O, Supreme 37 cm H2O, and include the critical gastric drainage channel to mitigate aspiration risk.
5.
SGADs are pivotal in the DAA, serving as the required rescue oxygenation device in the CICO sequence.
6.
SGADs are a relative contraindication if consistent peak inspiratory pressures exceed 30 cm H2O.
7.
Insertion must occur during adequate suppression of laryngeal reflexes, which often requires propofol but not necessarily muscle relaxants. The intubating LMA, the ILMA or Fastrach, is the dedicated conduit, and it requires the Chandy maneuver for optimal ETT passage.
9.
A critical trap. The LMA Supreme cannot be used for tracheal intubation.
10.
The most common complication is postoperative sore throat at 17%, which is preventable by using manometry to maintain cuff pressure between 40 and 60 cm H2O.
11.
Confirmation of placement with capnography is essential in all clinical and emergency settings.
That is a master list for revision. Now, let's wrap this entire revision session with a model conclusion, one that's suitable for ending that 20-mark answer and demonstrating clinical context.
Your conclusion should show progression. A strong model is supraglottic airway devices have fundamentally redefined the limits of safe, non-invasive ventilation, offering a rapid, effective, and hemodynamically stable alternative to tracheal intubation. While the first-generation devices remain crucial for spontaneous ventilation and primary rescue, the development of second-generation SGADs, with their improved seal pressures and the essential gastric drainage channel, continues to expand their utility into more complex surgical scenarios. Mastery of their specific design features, appropriate clinical application, and stringent limits is paramount for achieving safe and patient-centered anesthesia practice.
That was a tremendous structured deep dive, tailored specifically to give you the clinical nuance and the hard facts needed for your MD examinations. We've covered everything from Dr. Brain's modification of a dental mask to the critical role of the Chandy maneuver.
Remember, SGADs have evolved from a simple backup to sophisticated instruments that genuinely challenge the dominance of the ETT in specific selected settings. The clinical decision-making around these devices is now incredibly fine-tuned.
And here's where it gets really interesting, and this is a final provocative thought for you to mull over as you study your sources on aspiration prophylaxis. Given the success of the second-generation devices in settings like laparoscopic surgery, the boundary between the roles of the advanced SGA and the ETT is continually shifting. So, if the GDC made SGADs safer by managing passive regurgitation, what additional design feature, a truly revolutionary barrier, would be required to make an SGA the safest choice for every single patient, regardless of their aspiration risk?
Consider what it would take to achieve that definitive airway protection without tracheal invasion. That line of questioning will deepen your clinical understanding of why innovation in this space continues to be so essential. Good luck with your preparation.
Until the next deep dive, stay informed and study smart.